Good morning again, everyone. I need that because I'm going to need you to be a part of this discussion. If you're looking up at the screen, you see understanding the biopsychosocial impact of trauma, and the first thing that triggers most people is, oh my God. I'm about to go down a road of sheer, unadulterated boredom. However, as the cartoon would say, you don't know me very well. I'm Dr. Sims, Brian Sims, and I am a forensic psychiatrist, currently practicing. I have 30 years working in this category, and I've been blessed with that. I currently work out of 7 different correctional facilities, and I see a lot of inmates, and I used to structure a lot of the programs nationwide for the company that I'm currently working with. But as Raul has pointed out, and so often you'll hear throughout, the passion transcends any of those particular pieces of your history. The part that really sticks with me as far as trauma-informed began really as an issue around my residency. Because I was in a residency program in Baltimore, and this psychiatry residency actually taught us, and if you're ready for this, they taught us that trauma is a problem for the patient, but is not the central problem. Now, understand how cascading that statement would become. Because for us, what it meant was that we were then sent out as future leaders, people who the Joint Commission would recognize as running teams. So if we had that perspective in mind, we were already functioning totally against trauma-informed care. And I had my first test of it in a wonderful fashion. They said to me when I was a 4th-year resident, Dr. Sims, we are sending you to this pioneer state hospital called Crownsville. Anybody ever heard of Crownsville Hospital? It's in Maryland, just outside of Annapolis. Doesn't matter because they shut it down in 2004 and moved us everywhere else. But nevertheless, in my tenure there, I started off as a 4th-year resident. They said, Dr. Sims, you're going to be sent to this pioneer hospital where there's been no formal psychiatric training, so you're going to go in as the person that has the most knowledge about psychiatric principles. And it is your job to teach these poor dumb hicks how to do psychiatry. Being a 4th-year resident, all I needed at that point was to have my head exploded even more. And it grew and grew, and I barely dragged it into my car, and I drove myself to Crownsville Hospital Center, took my big head into the building, sat down in the group with them, and announced that the Savior has arrived. They looked at me and they said, fine, thank you for coming. We really appreciate you being here. And I proceeded to do what I thought I was taught to do, which was to espouse my knowledge. And I began to espouse my knowledge, and they allowed me to espouse my knowledge for 24 hours. Because in the 25th hour, the head nurse came to me and she said, and I quote, Dr. Sims, we don't like you. She then went on to open the doors for my formal acceptance of trauma-informed care. Because what she said next was, Dr. Sims, if you could just listen to what we do and watch what we do, then maybe you might have a different opinion. And we don't mind you trying to change things, but it would be a good idea to kind of watch it happen first. That was the opening door for me for trauma-informed care, because it began to mold and restructure how I interacted with others. Now, I have to add this little piece to it. They set me up as well, because the first thing they did was gave me a young lady who was in the seclusion room. And they said, you will go and see this lady in seclusion room, and she needs you to be her doctor. I went around, the door was open, and how many are familiar with seclusion rooms? Show of hands. Cool. Then what's the difference between a seclusion room and a quiet room? It's the door, isn't it? And the door in a quiet room is open. So as I go around the corridor, the door is open, the young lady's sitting there, I go inside, I sit down, and I begin to talk to her. And I begin to listen to her story. And as she was beginning to tell me the things that had been happening in her life, as my mentors had told me one time, major depression can quite often be diagnosed by someone telling you their story and it actually brings you to tears. She was bringing me to tears, telling me about what had happened to her. Now, Raul had talked about it. You all have heard this many times before. The essence of trauma-informed care is about discussing what happened as opposed to what's wrong with the person. And she told me that she's a lawyer and that she has 2 little children, both twins, and she was in the state hospital because she was found driving around the White House with all sorts of inflammatory statements on her car that she had put on there in posters. And she explained to me that she felt that her husband was having an affair, but that wasn't her trauma. What the real issue was for her was that she had applied to become a Supreme Court bench judge. And she received a letter back that she still clutched and carried in her possessions that absolutely berated her. And it told her how ridiculous it was for her to even think about applying. That was her trigger. And as we talked, I heard a lot of noise in the hallway, so I said, "Excuse me, ma'am, but could you just give me a second because I can't quite hear you?" And I went out and I shut the door. And I went back in and sat and talked with her. Thank you for laughing, because very rarely do people kind of get it right at that point. Thank you. Where was I, guys? Thank you. What's unique about a seclusion room door? Yeah, you don't exactly have a doorknob on the inside. So she proceeds to ask me, "Dr. Sims, how are you going to get out of here?" And I said to her, "No problem. I will just yell and somebody will come and open the door." She says, "Oh, no, you don't want to do that." Because everybody in seclusion rooms yells, nobody pays attention to them. Now I'm beginning to panic. So I then inquired of her, "How do I get out?" She says, "Don't worry about it, leave it to me." She then stood up, she went to the doorway, and she began to sing. Beautiful voice, beautiful voice. It drew not 1 staff person, but 8. And they came to the door to see this wonderfully beautiful lady singing in the doorway and this frantic doctor with his fingers clawing against the glass trying to get out. Okay? These are introductions, folks, to the types of things that we deal with and who we are serving. So we never lose sight of that fact, because sometimes as physicians or as mental health providers, we look at our patients in a markedly different way, like somehow they're just not quite where we are. But as Raul had very aptly pointed out, when you look at the general population statistics, we are them, and they are us. And we need to get that in our heads in terms of how we treat other individuals. So our journey this morning is going to take us through talking about our brain. I have to say, just from a qualification standpoint of view, our brains are pretty stupid. They're designed to do a lot for us in terms of keeping us alive. However, they're pretty stupid. I have dealt with so many people who have come to me that have said the following: "You know, somebody told me that there's a little bit of alcohol in antifreeze. And if I just drink that when I can't afford alcohol, I can get my alcohol intake." Somehow they had convinced that brain that it was okay, and that brain said, "Go for it. If it makes you feel good, do it." That's a problem, folks. So when we start relying on our brains, we have to be much better informed before we start asking that brain of what we might think is good and not good. As it pertains to trauma-informed care, I want to walk you through how our brains react to trauma. And I'm going to step you through that process first by taking a look at this particular slide. This slide is actually a longitudinal study that was done on children with burns. And if you just take away anything you see up there on the screen and just look at it as children with burns, if you can visualize how these children most likely are interacting with other children who then see the difference in that child with the burn, you can see that there probably are significant stressors. So this study took a look at these kids, and they brought them in, and they actually asked them questions that were part of a post-traumatic rating scale. And then what longitudinal studies do is they actually don't do anything formal treatment-wise. They ask them, they rate the scale, they send them out. And then after a specified period of time, in this case 3 months, they bring them back again. And they ask them the same questions. So the lines that you see on the left extreme of the line is where they answered their questions the first time. And on the right side of the line is how they answered the second time. The only thing I want you to glean from this slide is these lines are all over the place, aren't they? This is Raul's point to you earlier about everyone's response to trauma being different. Now, these kids don't have textbooks. They have no way to reference. These are feelings. But these are the things that mold when you see that adult and you begin to look at that adult as, oh my God, they're just defiant, they're just bipolar, they're just borderline personality disorder, without looking at the fact that many of them have been through this process in multiple different ways. Also, we must avoid, as Raul talked about as well, looking at leveling their stressors, leveling their traumas. Oh, well, that one rates on a scale of 0 to 10, that one rates as a 4. Because I know some other people who've had a 9 or 10. As individualized as this is, it should be teaching us a lesson that we need to avoid that at all costs. Now, I'm going to turn you just for a second into doctors, because this slide is an MRI. Now, all you young folks in the room, I'm an old fart psychiatrist, been around a long time, I have 3 wonderful grandchildren, and I've gotten to the point of the realization that if you don't know what an MRI is, you just need to get a little older. Because invariably, once you get a little older, you will find out the true meaning of MRIs because you'll have one done from the top of your head to the bottom of your feet. This is, however, an MRI of 2 11-year-old boys, and it's of their brains. And if I'm looking at you as I'm looking at you, it's a cross-section directly across this way. So you're seeing their brains straight back, okay? This study that DeBalis did were of multiple accounts. This is not just one slide that he did, of 11-year-old boys, kids who have been abused. Okay? And when I say abused, I want to make it very clear. The referencing that DeBalis makes is maltreated and non-maltreated. Mainly because DeBalis is a very wise individual. Because he couldn't talk normal or abnormal. Because I don't think to date, in 2012, we've been able to define what a normal 11-year-old actually is. But nevertheless, the one on the left is a normal, non-maltreated 11-year-old boy. That's an MRI of the brain. The one on the right is a maltreated 11-year-old boy. Maltreated, however, in every respect with exception of physical. No physical trauma, guys. No blows to the head, no strikes to the body. It was excluded out of this study. And I ask you the question, as budding doctors, do you see any changes between the non-maltreated on the left and the maltreated on the right? Okay, because I only want to point out 2 of them, and point may be a very difficult term here because I'm not sure if you can actually see. Can you see the red? Yes. Okay, good, I'm glad. That makes me feel good because I tell you, I see a blur from right here. Yeah. But anyway, if you look on this side, I want to point out 2 changes. One is, see this white line up here? Now look over here. That's one change. Secondly, see the openings here in the middle? Now look over here. Significant differences, correct? Let's just talk about the white line first. Because if you know, which I'm sure you do, that all this stuff is the brain here and all this stuff is the brain over here, white in an MRI denotes space. That's how space lights up, bright white. So if you know that, what does that tell you about this brain versus this brain? What about this maltreated brain? Yeah, it's actually smaller. It's shrunken, as a matter of fact. And I'll give you a good analogy of what shrunken actually means. I'm a movie buff, not so much like NCIS or anything of that nature. But if you remember Silence of the Lambs, and our old friend Anthony Hopkins, and the scene where he's got Ray Liotta at the kitchen table, and he's about to feed him his own brain. Well, if you remember, he takes the cranial cap off, and you get a chance to look at the brain. And if you know how the normal topography of the brain is, it has a lot of furrows in it, doesn't it? Those are called suture lines. And if you look at this on the left, you can see those openings here and here and up here and up here. See those? Now look at this brain. You don't see them. And the reason why you don't see them is because the brain has been compressed. It's actually squeezed inward. Now, this is repeated. This is not a single study piece. This is just a slide that we have in this particular presentation. But it's been compressed. And again, no physical trauma. The second are those openings that I pointed out here on the left, normal, here on the right, maltreated. You notice the openings are significantly larger in the maltreated individual. Again, consistently displayed by DeBailis. Well, the referencing that I'd make with that is that as a physician, whenever I see an MRI that has enlarged ventricles, which is what those are, I see them generally in one population, and that's the demented. Now, please, folks, I don't know how many of you are sitting in this room, but I will totally disavow if any of you take out of here that Dr. Sims said that maltreated 11-year-old boys have dementia, because I do not want that to be out. What I want instead is the opposite, that despite the macroscopic changes that you see between the maltreated and the non-maltreated, there is nothing that that maltreated individual cannot do. They can be in receipt of every single service you have to give them. But, and there's always a but, isn't there? It's how and what happens. So I'm going to keep you all kind of in mystery for right now. There is a reason why I'm showing you that slide. Now, Raul had given some of this data. I'll just quickly just want to bring up one point with you, that a lot of them are about witnessing. Because when he mentioned about the servicemen and so forth, I did my time with the armed forces, through the medical corps. I had an opportunity to actually talk to a lot of soldiers. And this was back when PTSD was not a known entity through the federal government. As a matter of fact, they had acknowledged that there really wasn't a big issue with it. So when I started interviewing the soldiers, one of the things that was very clear is roughly 80% of them had talked about their traumas being from things they witnessed and not things that directly happened to them. And this is something that we have to transcend and open up to look at outside the soldier in the general population, in the community. And when you have these data from children, you actually see that reality comes to perspective. When you look at the piece that talks about the children suspected of being victims of abuse, but more importantly, the one about 9 million witnessing acts of serious violence, I want to bring up one example out of the great city of Baltimore. And if you know about the great city of Baltimore, you know that Baltimore really struggles with being called a safe city. As a matter of fact, in 1997, they were listed for 6 hours as the murder capital of the world. And the reason why it was only 6 hours is because in the 7th hour, Detroit had misrepresented their data, and once they corrected it, they then became capital. But I'm just giving you that data because I want to point out something that may be prevalent wherever you go. Because there was an incident that happened in Baltimore that involved a mother and a father, and they are in a heated argument in their apartment. And this argument is escalating and escalating and escalating, and it gets to the point where the husband reaches behind him, pulls out a pistol, puts it to his wife's head, pulls the trigger, and kills her. He then takes the same pistol, puts it to his own head, pulls the trigger, kills himself. Now, for all of you, unfortunately, this is not a rare event. You probably have read about murder-suicides or had them occur, unfortunately, in the community. But I want to expand this just a bit further so it matches what the data is showing you. Because at the time that this murder-suicide took place, their 11 and 12-year-old children were seated in the living room and observed the whole thing. Now, to all of you wonderful providers, just yell out what you think happened to these kids within the next 24 hours after that event. I heard foster care. Sound like an auctioneer. Hey, do I have one for auction? What else? Questioning, absolutely. Tons and tons of trauma, absolutely. Shock, horror, absolutely. But I'm talking from a treatment standpoint of view. Because the lack of responses means that you guys get it better than a lot of places I go to. Because in reality, folks, this is reality. Nothing happened to these kids. As a matter of fact, these kids were sent to school the next day. Now, you got to understand, when you give that kind of response, what the popular thinking was. The popular thinking was, and unfortunately tends to be, if you send them to school, they'll be around kids their own age, and it'll kind of normalize this thing that happened. Is there any reason why now, when you see the adult that came from the child that experienced that you wouldn't be able to identify that there may be some trauma in that individual's life and how they deal with life in general? That's why we put these figures up, because we want people to also remember that the adults you see, at least from all of the medical school knowledge I have in my life, used to be kids before they became adults. Isn't that a revelation? Okay? PTSD, I will say this much, whatever statistics you see tend to be lesser than what they should be. Because to a larger degree, it's hard sometimes to get people to stand up and say, I'll be part of your study. For the most part, when you know individuals who suffer from post-traumatic stress disorder, the worst thing that they have is the outside world, because everything is triggering. And the last thing they want is to be triggered. So quite often, you don't find them standing in line for a study to be done, because they don't want to be around people. They don't want to have any flashbacks. They don't want to have any recall, because part of the problem with post-traumatic stress is that when they have these recalls, when they get triggered again, it affects them emotionally as if it occurred that same time. And sometimes years and years can go by. But look at the prevalence among the persons with serious mental illness. When Raoul said that if you practice universal precautions, you're going to be right. That kind of data tells you that we're spot on with that. But you have to ask the question. So if we are talking about looking at where things are, and we're going to treat it, we got to take a couple of things into account. First of all, we got to take a look at the nervous system in general and say, you know what, it's a bit dysregulated. It's a bit off from what it normally is. But secondly, that the social environment is not able to contain that dysregulation. That, to me, is an illustration of what's going on these days. What is the social environment? The analogous thing is that the village no longer raises the child. Now, for all you old folks, and I'm not asking for a show of hands, because I'm pointing the finger back at me, I remember the days when I was raised in a community, it's called Eastport, right, in Annapolis, where we had strict rules. The rules were, as an African American living in a mixed neighborhood, there were certain places we couldn't go. But being a child, that was almost saying to me, you got to go there. And quite often I would defy and get on my bike and I'd ride across into the forbidden neighborhood. And just before I would cross into the neighborhood, somebody from our side of the neighborhood, totally unknown to me, and may even be a stranger to my mother and father, would yoke my behinds off of the bike and would punish me for trying to go into the neighborhood. But that was what I referred to as the primary of a tertiary form of punishment. Because it didn't stop with the primary, did it? Because once that person then punished you, what happened next? Yeah, they called the parents, and mom was the one at home, and mom would say, send the boy home. The boy would get on his bike and ride home because you were more fearful of not returning home than going home. And when you arrived, you received the second degree of punishment. And then there was a tertiary component, because what would mom say? Thank you. You guys are really on target with it here. Okay? But I will share this little bit of information with you guys. I love my father dearly. He's been gone a long, 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 long time, but I can tell you that he's my reason for being a psychiatrist. Because my dad would get home after working 3 jobs, typical story you hear all the time, man, just work, 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 work. My mother would tell him what I did. And my father would then send me. And as I would go up the stairs, I'd go in the room, I would take out an old crumpled up sheet of paper, and I'd get a pencil, and I'd begin to will all of my toys and everything to everybody else, because I was very certain I was not going to come out of this alive. But he never laid his hands on me. He never had to, because just that piece there was modifying to the behavior. I'm only saying all of that to you because we don't have that anymore, do we? We're now in a society where if a total stranger yells at your child, can you spell litigation? Now, you also have to understand that these children that are not going through this process, who have gone through these lives of trauma, are ending up in our school systems, aren't they? I have a loving wife of 32 years. Lady Bug looked at me and she said, I'm retiring this year. I said, God bless you, go for it. But she would come home every single day and tell me about incidences that have occurred. And about a month and a half ago, she told me about an incident of a kindergartner who came into the school, and the teacher sent the kindergartner to my wife's office because she wanted her to see this. And the child walks in, and the child has stars done with magic marker all over her face, all over her arms. And my wife's going, oh, geez, look at this. I don't know, what's this child doing? Where did these stars come from? And the child said, oh, my mom drew them on me. And my wife looked a little bit closer, and inside of each of the stars was a bruise. And that child was then sent to the health office. This isn't years ago, folks. This is a month and a half ago. So when we talk about where we're going, there is an importance, there is a timeline, there's a following, but there's also how it affects what goes on upstairs here. And that's what we want to do, because we need to understand about how our brains develop. And our brains develop rather uniquely and individually, but they're also contingent and dependent upon a lot of different factors. And these core concepts of development help us to understand that, because the first one talks about how kids' developments do. And they unfold along individual pathways, which you already understand, but they're characterized by what are called continuities and discontinuities, as well as significant transition. What does all that mean? It means, folks, that as parents, caretakers, we are inconsistently inconsistent. Believe that? Don't believe that? Absolutely, in terms of how we present. Bill Cosby said it the best way. He said, we function as parents of the first life and parents of the second life. You ever heard of that before? He says, parents of the first life, this is what happens. You come into your kitchen as a parent of the first life, and you see your child dragging a rotten tomato tied to a string across the kitchen floor. As a parent of the first life, you say, what are you doing? And the child freezes, looks at your face, sees that you're upset, knows that probably they shouldn't have been doing that, and they answer you the following way. Nothing. He then says that as parents of the first life, you don't give up at that point. So you say, well, then why are you dragging a rotten tomato across my kitchen floor? And the child goes from nothing to psychosis, because the very next statement they make is, I don't know. And at that point, you've got no place to go, because they know how old they are, they know how old you are, and they can nothing you to death. Right? So he then talks about parents of the second life, who come into the kitchen, see the child dragging a rotten tomato tied to a string across the kitchen floor. They walk over, pick up the string and the tomato, throw it in the trash can, and say, I really would prefer that you not drag rotten tomatoes across my kitchen floor. Poll to the audience. How many of you are 100% parents of the first life? Show of hands. How many of you are 100% parents of the second life? Show of hands. Liars. Whoever raised their hand. I give you that. And I give it to you in one way and one way only. That is to remind you that all of you who raised your hands have been to the mall, haven't you? Of those who raised their hand, and everyone, for that matter, how many of you have been to the mall without children? Who went to the mall before you had kids? How many times when you went to the mall did you ever observe another child behaving badly? And how many times when you observed that behavior going, did you say to yourself, oh my God, if that was my child, I would never have any kind of behavior like that happen, right? And then what did you do? You went out and had them on your own, didn't you? And they invariably said, we want to go to the mall. And you find yourself at the mall, and they're behaving badly. And what do you hear in the background? Oh my God, if that was my child, I would never have any kind of behavior like that, you see? So there's this inconsistency that we see. Now, taking the humor from it and moving to a serious note, this is how neglect is seen. This is how abuse is seen. Because this is not routine behavior, is it? But it is something that the child, unfortunately, has nothing to do except work with it, because there's no book. There are many times that that child is abused by somebody that the child considers to be a caretaker. And even if it isn't a direct caretaker, if it's a family member, they then go to the one that they consider to be their caretaker and they say, Grandpa touched me in this spot. And the parent says, oh, no, that would never happen, and you're not ever allowed to talk about that. What do you think the child does with that? Where does it go from there? So you see, there's a lot to be said about this developmental pattern because it really makes a big difference. So I'm going to go through, because I want to take you through a couple of elements involving triggers and responses. Raul started talking about triggers and responses. But I want to kind of highlight what happens in our brains with triggers and responses. And then later I'm going to have you all participate in a little exercise that's going to get you so excited that what I would ask that you do is during your lunch hour, forego lunch. Don't even eat lunch. What I want you to do instead is walk out the door, go around and see Ed on the other side, who is the tour guide for the beautiful theater that's over on the other side, and I want you to get up on stage. And even though there's nobody in the whole audience, I want you to espouse the neurobiological knowledge that we're about to give you in just a few moments. But just hang in there for a few moments and we'll get to it. The thing about triggers and responses is that in all our formalized treatment, if someone gets triggered, do we necessarily want to see what the response is going to be? Is it necessarily going to be a good response? Probably not. So wouldn't it be a nice thing if there were a way to keep the trigger at the trigger level and not have it get to a response? Well, in our treatment profiles, folks, that's simpler than we think. And I want to give a couple of examples of what happens when a trigger makes it to a response with no intervention. I want to also point out that when I mention the word trigger, I also want you to understand that there are two other words that are similar. A trigger is a stimulus, is a traumatic reminder. All three are the same. Got it? This is audience participation time, so if you can say, yeah, okay, great. So stimulus, trigger, traumatic reminder. All on the same page? Good with that? Great. This first particular case involves Robert, and Robert's 22 years old. And the history you have with Robert is that Robert was abused physically by his stepfather. This went on for 11 years out of his life. And at 22 years old, he's now sitting in a psychiatric facility. And the green ball there that talks about calm, continuous, engaged, he's sitting in the day area. He's watching television. The situation is quite calm. Behind Robert, out of his view, is a table. And there are male and female staff persons sitting at the table, and they're talking with one another. So everybody see that scene? All right. How many of you have written in your notes, all of a sudden, without provocation, so-and-so jumped up, turned the table over, and hit a couple of people? All right, let's follow that with Robert. All of a sudden, without provocation, Robert jumps up out of the chair, huge look of anger on his face. He charges the staff's table and he tackles one of the male staff persons to the floor. Immediately, forces are called in, they grab Robert, they start heading towards the seclusion room, and they notice that that angry look on Robert's face suddenly turns into one of abject fear. And by the time they get him to the seclusion room, he's now in a state of dissociation. He's no longer responding to verbal commands. He's obviously living. He's obviously has good vital signs, but he's not responding. Now, in a long-term sense, which we do not have the time for, we would have explored with him the normal way that our hospital would have done it. We would have brought Robert in, and we would have said to Robert, "Do you know what you did yesterday?" And Robert would have answered in kind, "No, but I'm sure y'all gonna tell me." Instead, we try to approach it from a trauma-informed perspective. We bring Robert in. We don't put him through the Spanish Inquisition, which I call. which is an arc of chairs with a bunch of staff persons and one chair just for Robert, and we proceed to just bombard him with questions. Instead, one person, being the lead, would say to Robert, "Robert, what happened to you yesterday?" And when that question was posed to Robert, he said, "You know, I was fine. I was sitting there watching television, and I thought I heard the voice of my stepfather." That was Robert's trigger. There were no intervening elements to keep him from getting to the response, and that's the response you saw. Now, we're going to build on that, but the second one is a young lady, 12 years old. The history you have with her was that she was sexually abused for a while by one of her family members. At this point, she's in school. And it is calm, it's engaging, it's quiet, learning is going on. And a male peer leans over and says something sexually inappropriate in her ear. Just whispers it. She jumps up out of the chair, huge look of shame on her face. The teacher tries to engage her, but she runs right past the teacher and runs out of the classroom. Teacher knows that the principal's office is at the end of the hall, calls the principal. She steps out of her office. The child runs towards the principal. The principal's expecting the child's going to stop. She runs right past the principal and goes out the front door. The principal knows that this child lives 3 blocks away, calls the mother and says, "We don't know what's going on. Your child is very upset. But she's headed home." Mom steps out on the porch, sees the child coming, can see the abject look of fear in this child's face, fully expecting her daughter to stop and say, "Mom, this terrible thing happened," but she runs right past Mom and runs into the house. Now Mom is turning around. "What's wrong? Talk to me. Tell me what's going on." The child runs upstairs, goes into her bedroom, goes into her bathroom where she's hidden a knife behind a medicine cabinet, and she proceeds to start cutting herself. All the while, Mom is still asking, "Talk to me. What's going on? What's wrong?" We don't necessarily need an explanation on the second case, but we are talking about triggers getting to responses without any intervention. And you can see how prevalent that is in the lives of the people we are currently serving, because of how many times you've had these quote-unquote unprovoked elements happen. A lot of times they are triggers that just do not have any kind of alternative strategy or anything put in its place. But we're real good at picking up the symptoms, aren't we? We can tell the change in affect, can't we? We can see the thought process change. We can see how the behavior changes. We can see how demeaning and somewhat low their own self-esteem tends to be. But we quite often miss this last one, which is that level of consciousness. Because sometimes we are triggered by their triggering. And we tend to label that last piece as they're just being obstinate, defiant, they don't want to talk to me. We got to keep that piece in mind, that piece is very prevalent. Now, what's our goal? If we're going to treat these individuals, what is our goal? Is our goal to maintain a calm, continuous, engaged environment? Because if it is, then you're talking about getting back to what I used to do. Now, as a physician, if you called on me and you said, "Dr. Sims, we have an emergency. John has just turned over several tables and he's punched a couple of people. Dr. Sims, we need the cocktail." You all familiar with the cocktail? All right. The cocktail usually asks the doctor for 3 items, usually an antipsychotic, usually something to calm them, and then in a compassionate way give them something to prevent extrapyramidal side effects. Now the doctor, being the doctor, and understanding that he still has to work with that staff the next day, and was not a part of the emergency to begin with, says, "Go for it." And the medication is administered, and another call comes back to say, "Thank you so much, Dr. Sims, because everything is quiet now." My question to you, if you get it back to the calm, continuous, engaged environment, have you settled the problem? Good. I'm so glad you all are so spontaneous and so loud with that response. Now, I know that I set you up, but I failed on this because I wasn't supposed to show you that second one. I was supposed to leave the first one up and have you guessing. But you know that it's not there. It's not about that being a shock to you. But you know if you just make the environment quiet, you haven't figured out why it happened to begin with, and you haven't figured out if it's going to happen again. And for a lot of you that have worked in these settings, you know those two could happen at any time. So what we need to do is not only get it back to the calm, continuous, engaged state, but to prevent it from happening again by putting in things that allow this individual to have choices when they're triggered, choices when they have a traumatic reminder, choices when they have that stimulus. Got it? Good. I like it. See, just follow him. Okay. So, folks, now, audience participation. For every stimulus, there is a... Oh, that's sad. That's really sad. Let's try that one again. For every stimulus, there is a... Okay, that made the button come up, all right? So here's the thing about stimulus and response. A stimulus is a trigger, is a traumatic reminder, right? How much time do you have between the stimulus and response? Is it slow like what you guys just did? No, you don't have a whole lot of time between the stimulus and the response. So you know you have to act fast, don't you? So how do we act? Quite often we act in the following fashion. We put together two things. One is called social environmental intervention. The other one is called neuroregulatory intervention. What is social environmental intervention? It is the most powerful tool that is so underutilized in treatment. I told you guys in the beginning, our brains are dumb. But we got to use them more. We have to use what works, because sometimes what we're guilty of is we actually start to use something that works, and then we stop using it. We don't have a reason why we stop. We just don't do it anymore. But in this situation, quite often, we don't use social environmental intervention because we move towards neuroregulatory. But what is social environmental? It's what you've been doing all along. It's what you do with your kids. It's what you do in your settings. You see someone upset, you walk up to them and you say, you know what, you look upset. Would you like to take a walk with me? How about let's go down the corridor together? How many times have you done that? Show of hands, and the person has actually gotten calm and actually de-escalated. My God, what a powerful tool. How much did it cost you, by the way? Okay, cool. Why aren't we doing that? Why aren't we doing that more often if we're that good at it? If we're that productive with it? Well, it's because, for the most part, you keep calling on me, which is where neuroregulatory intervention comes in. Because it's a lot easier to say, oh my God, they're upset, they need a PRN. And they call Dr. Sims. And I told you, I'm going to say yes. But I want you to understand that when you ask me for medication, and I grant it, and you provide it for the individual, are you eliminating the stimulus, or are you eliminating the response? Response, thank you. And you can say it more comfortable now. Response. That is what the old folks call shutting the barn door after the horse got out. Because in essence, you've done nothing about what started the process. You just shut down the response. That's where I want people to begin to focus. I've been promoting and prescribing medications, and still do, for the past 30 years, guys. I am not sitting here telling or standing here telling you that medication does not have its place. I just want people to better understand that when you call on medication, you're not taking care of the situation. Medicines do not cure. There are very few medicines that cure. The only one I know of is athlete's foot. But beyond that, when you use psychotropics and you use other types of agents, you're not talking about curing, are you?